we're going to overlap a lot of our presentations, and the main reason is, in my case, to have a good deployment, you must first plan very well. So these things are so closely related that we cannot separate these different aspects in our presentations. As you've heard about the T-branch, how it is composed, it's always very important to know your graft, as Pedro has said before. And our setup when we are, and my talk is mainly about OR setup, technical deployment, aspects of the deployment and tips and tricks. And it's very important to have a whole setup already in place with your team, with anesthesiologists dedicated to these procedures, intensive care unit prepared to manage your patients, especially about spinal cord ischemia that Gonçalo will speak later. And it's fundamental to have good image quality. The ideal setup is, of course, a hybrid room, but if you don't have a hybrid room, please do these cases on an angio suite, because you will face a lot of risks doing these kind of procedures with a C-arm, and you don't have enough quality to finish it well. It's, we always do in T-branch cases, we've already talked about indications, CSF drainage, because these are patients at a very high risk of paraplegia, of spinal cord ischemia, and because T-branch always implies a lot of aortic coverage. So we tend not to be selective in these cases and drain in all of them. These are our main goals during the procedure: maintain good hemoglobin above 10 milligrams, and also very careful with anticoagulation to ACT times of 250, 300. Access vessels is very important, and as Pedro has talked, and planning these and take access vessels in consideration when you're planning a T-branch case, because it's a 22 French delivery sheath. You can have from Cook low-profile T-branches as side order to have on your shelf, but the main the T-branch original is also always 22, so you must be aware about access. If needed, use iliac conduits, maybe one thoracic. We normally have 2 femoral access, but if you're not doing a bifurcated device, maybe you can live with 1. And always access your arch calcification and plan how you're going to position your sheath through the axillary artery and the aortic arch. We always go for surgical exposure and use purse strings, because we believe that perfuse quickly, as soon as possible, the lower limbs will reduce the spinal cord ischemia. And again, careful planning is a half of a successful deployment. A lot of adjunctive procedures are needed in most of cases, but normally thoracic endografts. Pedro also already spoken about this. And in access, we should not compromise with bad access, and maybe if needed do surgical conduits, endoconduits, even simple angioplasties and stent placements to avoid complications. As we all know, T-branch is a compromise about a perfect fit, and we should always think of this when we are planning. And when we're deploying our graft, we should have in our mind the ideal position for the graft in terms of level and orientation, so you can achieve the best compromise for all 4 vessels. And sometimes it can mean to be more favorable for a more difficult target vessel, and assuming that you may have a more difficult catheterization of an easy vessel to be sure that you can finish a procedure. Let me show you this case, and I think the best way to look at deployment is to look in a case. This is a case of a 73-year-old man with a type 3 aneurysm with 8 centimeters. We could not wait for and we don't like to wait for a custom-made graft with such big aneurysms, and he filled the criteria for the T-branch. So we normally build these cases from top to bottom and try and always deliver all aortic components first, so you can perfuse the limbs quickly. Maybe the exception is when you have narrow aortas at the renal level. You might benefit of not opening the T-branch completely at the renal arteries level and catheterize first from above, so you have more room to play with. But in most of our cases, we open the whole aortic graft so we can perfuse quickly the limbs, and then you have all the time to come through the upper axis and catheterize your branches. Again, twisting and malrotations and malpositionings of the graft, it's very, very crucial. A lot of times this graft is very long and it can come twisted inside the sheath, so you must be aware of that when you're opening, and it's easier to correct it while you're unsheathing the device than after opening the whole device at one time. Then sometimes it's even impossible to correct the twist. So you must be very careful while deploying the graft, looking at your markers and in correcting, if necessary, with rotations, the twisting of the graft. Sometimes, not in our experience, but sometimes a through and through guide wire to help stabilize your graft when you're opening can help. It's when you're deploying the graft, it's better to be a little higher and more proximal than lower. You must always check that all your branches are higher than your target vessel, because if not, then it's almost impossible to catheterize the branches. And again, try to achieve and to choose your best compromise for each target vessel, and plan this not only inside the procedure, but before going, knowing maybe if I give a 1 o'clock, 1 hour offset of the graft, then it probably will be easier for a difficult renal, even if I have to then deal with an SMA that's not completely aligned. And the branches we always cannulate from top. There's, and I'll show you in a little while, now some reports of catheterizing through a femoral access. But we normally position a 12-French sheath across the aortic arch and inside the T-branch, and so you can have stability. Sometimes this is you don't achieve the stability that you desire to be comfortable catheterizing, so a through and through 014 wire can help to stabilize your sheath and your catheter and work much more comfortably, as you can see in this case. And in this case, you can see, Pedro also already talked about it, we always do two projections, and this is the final result of this case after 2 years. As you can see, with a good patency of all branches and a complete exclusion of the aneurysm. Bridging stents are also very important. We must be aware that we don't have the ideal bridging stent. For us, Viaban is probably the most adequate for renal arteries due to its more flexibility. However, it has some difficulties, mainly visibility during the procedure, and sometimes it doesn't have such a good radial force to fix on the branch. So feel liberal to use relining stents or even covered stents to have the Viaban more closely attached to the branch. Advantages are mainly our stent of choice. They are very easy to use, but they do need a lot of relining because they are less pliable and have more tendency to kink. Relining can be done just for correct and allow to have a more stable fixation in the branch vessel, but also to correct some kinks on the bridging stent that can happen in this, especially when you have upward renal arteries, for example. Let me show you this new technique that the group of Stefan Hollon has presented is to do an all retrograde approach to the branches. It has the great advantage of not manipulating with the aortic arch, and you use a steerable guide sheath like Aptus, and all from femoral access you can catheterize your branches and your target vessels. In their experience, they think this can reduce procedure duration, but you need to work with low-profile bridging stents, so you must adapt and be ready to have all the materials to do these cases. And finally, let me show you one of the bailout techniques when you cannot catheterize a target vessel. This was described by Marcelo Ferreira from Brazil, and this implies that you don't finish all the aortic components, so again you must be prepared to deal with a difficult vessel like it can happen, and you should not finish the whole aortic graft, bifurcated graft, and you can catheterize the target vessel from below, access it with a wire, a stiff wire, and then use a snare through this lower axis to progress the wire that is coming from above from your branch and achieve a successful catheterization. So just to finish, and again, planning is very, very crucial. You need to plan the best way, the best compromise to reach all your target vessels. You should adapt to the patient. Sometimes modifications of the graft can be done, like taking 1 or 2 proximal stents. Think of adjunctive techniques to help your procedure, and try to choose your best bridging stent according to the anatomy of each target vessel. And again, be very aware of the twisting of the graft inside the sheath. Thank you very much.